Hi, I'm June Sadowski, a dentist geriatrician, and not only am I a specialist in dentistry and in geriatrics and at the intersection of these two disciplines. Today, I want to focus on how disabilities may affect oral health through this Houston Geriatric Education Center program. This project is funded by a grant from the Health Resources and Services Administration of the Department of Health and Human Services. The grant was initially funded in 2007 with renewed funding for 5 years beginning in 2010. The learning objectives. Today I'm here to talk about oral health and with a focus on disabilities. What are the risk factors? What are the manifestations, the oral management and interventions? After this presentation, the student will be more aware of how disease is manifested in the oral cavity. This is a School of Dentistry located south of Braeswood Bayou in the South Campus area of the Medical Center. I would like to give you a rundown on all things that happen here. Our curriculum prepare men and women to become some of the finest dentists anywhere. It takes 4 years. We also prepare dentists to become specialists in endodontics, orthodontics, periodontics, and prosthodontics, and oral surgery. Also, UT Dentist is a private practice made up of our faculty. The value of treatment by our students and specialty students is unmatched and is approximately 1/3 to 1/2 of dental care fees provided by Houston's private practitioners. We also have low-cost student emergency and limited care clinics. So what are the risk factors? These are those listed. Does a person have a chronic disease? What are the factors that are around us daily? The environment. The example would be if one lived in an area of pollution and lived with fluoride or no fluoride. Do they smoke? Do they drink, take drugs? And lastly, the things we think of as bacteria-driven and can be cured, which is periodontal disease and caries. Let's look first at periodontal disease. We see cardiovascular disease and periodontal disease are linked, and periodontal disease is a risk factor for cardiovascular disease. This is a good demonstration of how periodontal disease progresses. On the left is a picture of healthy teeth and periodontium, and on the right you see where the bone is decreasing and how it progresses by the buildup of plaque and calculus. This is a 1998 reference, and newer ones connect inflammation found in heart disease, especially the one that deals with Berger disease, which is an inflammatory occlusive disorder affecting peripheral blood vessels. What are other risk factors? Medications, particularly if they reduce saliva flow, which can be detected by a dry, bald tongue. There are 3,942 medications that cause dry mouth. Also, if medications are not taken correctly, there may be interaction among the other adverse effects. There are autoimmune diseases like Sjogren's syndrome and HIV, which have dry mouth associated. Chemotherapy drugs, as in cancer treatment, can change the nature of saliva and the amount produced. This may be temporary, with normal salivary flow returning after treatment. Radiation treatments to your head and neck can damage the salivary glands and cause decreased saliva production. This can be temporary or permanent, depending on the radiation dose and the area affected. Finally, diabetes, both type 1 and type 2. These risk factors are modifiable, and their management is a major component to the contemporary care by many periodontal patients. This is a consensus statement written up in the American Journal of Cardiology and the Journal of Periodontology, and was groundbreaking because it had joined forces to educate the public of the increased risk of heart disease and how that's been diagnosed in people with periodontal disease. It's very interesting in the second bullet to note that the British Medical Journal in 1989 was the first to find that unexpected correlation. Let's look at caries risk. In this study, 85% of the subjects had coronal and/or root caries, and over 75% were taking medications with hyposalivary side effects. There was a lack of fluoride, and the saliva was very acidic. Let's look at some of the environmental factors. The University of Wisconsin Population Health Institute model, made in 2012, shows how environmental factors affect our total health. Among them are societal health care systems, cultural values, education, and healthy promotion of lifestyle choices, and of course, your work-related environment. Let's look on the next slide. This is a depiction of all of how the factors work together. As you can see, the social and economic factors are affected by the policies and programs that can be instituted. That can be the built environment, as you see on the lower right. Whether you live in an area with a lot of parks, whether you live in a dense inner city area, makes a difference. What the environmental quality is how pollution, or if you live in an area of fluoridated water. Also, the social and economic factors are how much do you fear your life, that's community safety. Do you have a fair or equitable income? Do you have family and social support? Are you employed and are you educated? Those are the qualities that make up the health factors. Because if you're educated, you can make choices based on that education. The health factors are based on clinical care and health behaviors. And those are access to care and the quality of that care, if you're able to get the health care you need. At the top in green shows that 50% is based on how long you will live, i.e. mortality. For example, if you live near a spot where they dumped chemicals, you might get cancer and die young. The other half of the environmental factors is the morbidity, or how your quality of life is. A longer life would mean more good effects. Another way of looking at those socio-behavioral risk factors is in the writings of Marc Lalonde. He was the former Minister of Health in Canada and really began the whole Canadian healthcare system, how public policy can affect healthcare organizations, creating and helping your population achieve a lifestyle to deal with life, including recreations, and adding support for our elders, and how we could try to help income inequality. This is another aspect of the risk factor approach adapted from Peterson in 2003, which focuses on an outcome in which oral health is the focus, general health and quality of life. So you can see the healthcare system, how you utilize it, what your risk behaviors are, and then what the outcomes are, which would be better oral health or a general better quality of life. Our health status is affected by tobacco and alcohol use, also by a well-balanced diet, and if we go for regular checkups. And to the dentist, we need to go, be it every 3 months, 6 months. It's always tailored specifically to you, whether you use fluoride and whether you remove the plaque from your teeth twice a day. I noticed I didn't say brush. I said you have to clean your teeth. Your dentist or hygienist will tell you how well you're doing and if you are brushing them enough to get them clean. This is a caries management by risk assessment. And since caries is entirely curable, an assessment to find and eliminate that etiology make an educational plan and perform that education, make a treatment plan to repair any areas, and take steps to complete the patient motivation and lead to a caries-free condition. I want to switch gears here and talk a little bit about what the chronic diseases are. These are the major ones, and they represent about 60% of deaths. That's heart disease, stroke, cancer, chronic respiratory diseases, diabetes, and bone and joint diseases. So we're going to talk now about the manifestations of systemic disease. These are GI diseases which have oral manifestations. These diseases, Crohn's disease, ulcerative colitis, and GERD, all of these have manifestations in the mouth. Because of the acidic nature in our stomach, it can cause erosion of natural tooth structure and severely change the geography of the tongue, mucosa, and lips. Chronic liver disease is another condition that can have oral manifestations. What are those chronic liver diseases? It's either a liver dysfunction or a viral infection, which both have signs in the mouth. They affect the tongue with xerostomia and bruxism and may have a crusty rash. You can also have lichen planus, Sjogren's syndrome. There may be white patches on the inside of your cheeks and a bald tongue. There may be a vitamin K deficiency, and along with excess bleeding, decreased coagulation, you may develop splenomegaly, and those are seen in the mouth as bright red tongue and irritated red gingira. Also, we have to remember that in the liver is where many things are processed, from dentist use of local anesthesia and analgesic, as well as antibiotics. In chronic kidney disease, there is a decreased kidney function or kidney damage. This disease has many etiologies, but sometimes chronic NSAID uses can cause that and is on the rise to cause kidney damage. Oral symptoms may be that ammonia-like smell, and sometimes you see a frost on the skin where the sweat is dried and that contains urea. And the person usually has a large amount of thirst, has xerostomia, gingivitis, sometimes stomatitis, inflammation of the parotid or other inflammatory areas. Anemia is another chronic disease that comes sometimes in kidney and liver disease that can cause an alteration in the hemoglobin. And if you have a gastrectomy, that can lead to a B12 deficiency. And the oral manifestations are pale gums, you may have glossitis, you may have angular stomatitis, or pica, which is the desire to consume sort of unusual substances. Let's look at the connective tissue disorders. Sjogren's syndrome usually are in females over 50, 90%. And with it can be dry eyes and mouth, which is the Sika syndrome, if it includes more than 2 or 3 areas. Xerostomia is always the cornerstone of it, and atrophy of the papilla produces a tongue that has no papilla on there and is bald and cobbly looking. There's also an increase in infections, and it may be very painful. That dry tongue is very painful. You can't have any kind of acidic substance on it because it will really burn. It also includes lupus erythematosus, scleroderma, and polymyositis. Let's look at some pulmonary conditions that have oral manifestations. COPD is the major pulmonary condition that we're dealing with right now because of the age of people and where smoking was in 90% of the people. It also may be caused by other pollutions, air pollutions, but it causes irreversible damage in the airways, and you have restricted movement in breathing. You may be breathless, you may cough, you will have irritated gingiva and irritated soft and hard palate because of your inhaler use. And your mucous membranes can be very, very dry. You will be more prone to having upper respiratory tract infections, and people with pulmonary conditions have more dental caries, and it can discolor the teeth. In Wagner's granulomatosis, it's strawberry gingivitis, and it's one of the first presenting signs in a multisystem autoimmune vasculitis. Let's look at diabetes. It affects 1 in 4 Americans age 60 and older. The number of adults age 75 with diabetes, there's over 1 million in 2000, and there will be more than 4 million in 2050. So this is just statistics to show you how 1 of every 4 people at the age of 60 will have diabetes. 82% of diabetic patients with severe periodontal disease have experienced 1 or more of cardiovascular disease, cerebral vascular disease, or peripheral vascular disease, compared to only 21% of diabetics without periodontal disease. This slide demonstrates that when one is diabetic and it's uncontrolled, the collagenase can degrade your periodontal tissues. Also, with this disease, which is inflammatory in nature, produces this pro-inflammatory cytokine, and it causes more insulin resistance. So once you have your periodontal condition in order, you can stabilize those, because it shows that in diabetic patients who had full mouth disinfections every 3 months showed a decrease in the HbA1c levels. Let's look at arthritis. It is a disease of the bone and joints and muscles, and it's one of the leading causes of disability. It affects 8 million people, and it causes you to have loss of motion, stiffness, joint deformity. You can become overweight because you don't exercise regularly. You might be fatigued. You might have unexplained fever. It can also affect the temporomandibular joint area, the TMJ. The studies that I think of whenever we talk about them is that a number of manifestations are in rheumatoid arthritis patients, both Sjogren's again and xerostomia. And also, if they take methotrexate, that induces some ulcers in people who take that. Oral mucosal involvement in autoimmune diseases, including rheumatoid arthritis, occurs in high frequency. More studies are needed to determine if secondary, if you only get Sjogren's after you get rheumatoid arthritis, is associated with periodontal disease. But in the next slide, you can see that there are several types of arthritis, which is osteoarthritis and gout, which might be from uric acid buildup in your system. And they all have that C-reactive protein in the blood serum when it's in acute inflammatory stage. This is the most recent study on the prevalence of periodontal disease in people who have arthritis. And this prevalence estimates that they're significantly higher than prior reports of people with arthritis and periodontal disease. My last slide on arthritis uses Ina Haynes' report to look at the associations between periodontal disease and rheumatoid arthritis, and suggested that the prevalent rheumatoid arthritis in those with missing teeth, that there is an association. In the general population, rheumatoid arthritis sufferers is about 1%. Those referred for periodontal treatment, the prevalence is almost 4%. In those that needed no periodontal treatment, it was a little over 1%. So the take-home message is that if you have periodontal disease and arthritis, rheumatoid type, you might need to bring that under control to help both your arthritis and your periodontal disease. This shows that referred patients with rheumatoid arthritis, the other side, that there is also a prevalence for cardiovascular disease and diabetes. This one takes the conclusions of the study and talks about that individuals with moderate to severe periodontal disease are at higher risk for suffering from rheumatoid arthritis, and vice versa. People with rheumatoid arthritis are more likely to have periodontal disease. Let's look at osteoporosis. What is the role of osteoporosis in bone loss in the jaws due to periodontal disease, tooth loss, and other oral tissue changes? People with osteoporosis have weakened bones. There's a loss of the bone mineral density. Good home care is absolutely essential. Osteoporosis that is now treated with bisphosphonates have a risk to establish osteonecrosis of the bone. In this example, this is a female who was in a nursing home, and she was fed by an aide who didn't realize she had this tori. And so when she put the spoon in, she would bump the tori. And as you can see, this became denuded, and now the bone has died, and you can see dead bone peering through it. It's no wonder that the patient didn't really want to eat anymore. Let's look at some of the oral manifestations of viral diseases. This is an example of what herpes on the lips look like, herpes gingivalis, and then intraoral herpes on the lower left. On the upper right is herpes zoster, which is a appearance of that herpes called shingles, and it's from the chickenpox virus. There are others, which is the human papillomavirus, the squamous cell papilloma and verruca vulgaris, and human immunodeficient virus, HIV, and one that you can also see that's present are warts on the hands, plantar warts. So the human papillomavirus can progress into a cancerous state, and it's on the rise at this time. Just a short bit on head and neck cancer. These are some statistics, what the incidence in 2012, and they have not significantly changed in this 2014. And I think that the oral side effects of cancer treatment is great, but I think that one thing that people who do treat cancer, they have come up with many preventive measures and making sure that the patient understands what effects will happen. For example, they do a great job shielding if the cancer is in the head and neck area and titering the dose so there's not an overabundance of that cancer-killing drug that it might kill some good drugs. I think that also they do help patients by asking them to have any dental treatment completed before they begin their cancer treatment. That helps from any problems arising. So they are on the preventive side. Let's look at some of the drug-induced oral manifestations. They might be mistaken for signs of disease, and they may affect any system or any structure. These are some that are aphthous stomatitis, lichen planus, gingival enlargement, which is hyperplasia, which is caused by taking phenytoin. Sometimes people who take calcium channel blockers or even cyclosporine have that gingival enlargement. A lot are affected with dry mouth because that is an anticholinergic effect, and any drug that affects that cholinergic system can cause xerostomia. It may involve causing an unpleasant taste in your mouth or even a swelling of your lips or tongue. It can cause black hairy tongue. It can cause neuro and muscular disorders such as tardive dyskinesia when you're taking certain drugs. The mouth may become infected with bacteria or fungi, or even cracking of the lips and in the corner. This is a picture here of lichen planus on the lower right. This is an example again of dry mouth. These are other drugs that induce oral manifestations. In 50%, the medications manifest themselves orally. Antibiotics such as penicillin and sulfonamides, or even a class of anti-seizure drug called phenytoin. There are drugs that can cause neutropenia and results in ulcers on the gingiva as the cells lose their integrity. They can cause fungal infections, candidiasis with chemotherapeutics or immunosuppressives. Sometimes the symptoms don't show up until 3 weeks after you take the meds. This is an example of candidiasis. This lady had candidiasis for several days. At this point, it was itchy and it burned, so she kept licking her lips over and over. The first day, there was the bloom of the fungus, which is white or yellowish white. As time goes by, that's rubbed off and it becomes very irritated and reddish, and it burns and it hurts. Now I want to talk about some of the diseases and the oral management of them. These are resources on oral management of people with Alzheimer's and dementia, particularly these with stroke, because stroke patients don't realize that they have teeth on their affected side, and so they won't brush those and food will pack in them. Even those people who wear dentures before the stroke, maybe they were new, maybe they were well-fitting. After the stroke, there will be loss of muscle movement and the dentures will fall and not be effective. And we think they're not good anymore, but it's just the fact that the muscles do a tremendous job of holding in the dentures. In movement disorders, it's the ability to maintain oral care, preventive care. Parkinson's disease, there's major problems in swallowing saliva and the drooling and management of those oral symptoms. Some of these people can't complete their own activities of daily living, which are ADLs. Disease and oral management. Because the population over 65 is continuing to increase, the global oral health of the elderly is poor worldwide. And prevention is not emphasized, so we need to make more emphasis on that. And we need to start reminding people earlier that they will have teeth when they're 90, and they need to seek preventive care and regular checkups. Because more teeth are going to be kept, there will be more teeth that will be at risk. In long-term care, there are issues with oral management. There are patient consent issues because they don't have their own consenting ability. They have unacceptable levels of oral hygiene now, and there's lack of knowledge by the caregivers of how to manage oral care. In homebound, people are isolated and have no one to really help them with their oral care. And in hospice and then oral cancer patients, these are the majority of the elders. So it's beneficial to introduce the practice of good hygiene skills at an earlier age and providing training for all ages. Earlier education should decrease problems in the future cohorts. What are the other barriers to dental care? Well, access, the transportation problem, how do they get there? Can they sit in the chair whenever they do get there? Is there enough room for the wheelchair? Housing, what if they don't even have housing? If they live in abandoned cars or wherever people are living crowded or with relatives or with friends. There are also legal issues. Do they have a VA benefit? Because I know many homeless elders are veterans and they have a tough time seeking dental care. Now we have alien status, because if they're not part of this country. What are some of the interventions? Well, we look at education. We need students and faculty to retain their patients. We need entities that are caring for seniors to understand what the management options are. There is linkage to community resources. We need to improve transportation, caregiving, and outreach to citizens that are seniors concerning their dental needs. This is one of the things that I think education-wise is a good bargain. If you go to this website, it's the caregiver training video, which is designed for nursing homes and assisted living. And you might even make a donation of one to a facility near you. It's a real live management option. We need to make dental offices more elder-friendly, where it's lighted, it doesn't have obstacles in the way. We need to understand that they need us to speak slower, that they need to write things in bigger print. We need to educate their caregivers why they need to help them brush their teeth. And if they have had a stroke, to brush their teeth completely, that they can't brush their teeth at all, the patient. We need to learn how to alter toothbrushes, or how to help patients alter the toothbrushes. We need documentation for daily oral care so that people can know, well, I brushed my teeth today, but they might not remember. We need more portable dental equipment. We need more mobile facilities, more ways to bring dentistry to where it's needed, in the homebound or in hospice. These are my references. There's about 4 pages. If you have any questions, this is my office phone number and my email address. Down here is new patient information. Please contact me. Thank you so much.